Good evening, Dr. Phil here. Today we'll be discussing on Fluid Dynamics Part 1, Laminar and Turbulent Flow. Flow is the volume of liquid passing a fixed point per unit time. It can be either laminar or turbulent. Fluid is a flowing substance, such as gas or liquid. Flow in the airways and blood vessels is a mixture of laminar and turbulent flow and behaves approximately according to the following concepts. Laminar flow. Laminar flow describes the situation when any fluid passes smoothly and steadily along a given path. The flowing fluid can be visualized as a series of parallel laminae. A molecule of a given substance maintains a constant spatial relationship to all the others that are flowing in the same lamina. In a tube of uniform diameter, the leading edge of a column of fluid undergoing laminar flow appears parabolic. Fluid flowing in the center of this column moves at twice the average speed of the fluid column as a whole, and flow is greatest in the center of the tube, while fluid flowing near the edge of the tube approaches zero velocity. The Hagen-Poiseuille equation is used to describe laminar flow in a tube of uniform diameter. Flow equals delta P pi r to the power of 4 divided by 8 eta L, where delta P refers to the pressure drop along the tube, r refers to the radius of the tube, eta refers to the viscosity of the fluid, and L the length of the tube. It can also be expressed as flow equals delta P pi diameter to the power of 4 divided by 128 eta L. Flow is directly proportional to the pressure gradient and the fourth power of the radius. Flow is inversely proportional to the viscosity of the fluid and the length of the tube. If radius doubles, flow through the tube increases by 16 times, which is 2 to the power of 4. The Hagen-Poiseuille equation applies only to Newtonian fluids. A Newtonian fluid is defined as any fluid that demonstrates a linear relation between the applied shear stress and the rate of deformation. Viscosity remains constant no matter the amount of shear stress applied for a constant temperature. Examples include blood plasma, water, mineral oil, gasoline, and alcohol. A non-Newtonian fluid is any fluid that does not demonstrate a linear relation between the applied shear stress and the rate of deformation. The viscosity of the fluid changes when shear is applied to non-Newtonian fluids. There are 4 types: dilatant, rheopactic, pseudoplastic, and thixotropic. In dilatant fluids, viscosity of the fluid increases with increased shear stress. Examples include quicksand, corn flour plus water, and silly putty. In rheopactic fluids, viscosity of the fluid increases with increasing duration of shear stress. Examples include gypsum paste, cream, and synovial fluid. In pseudoplastic fluids, viscosity of the fluid decreases with increased shear stress. Examples include blood and ketchup. In thixotropic fluids, viscosity of the fluid decreases with increasing duration of shear stress. Examples include paint, cosmetics, asphalt, and glue. Resistance to flow is defined as the pressure change per unit change in flow in cmH2O per liter per second. The formula is R equals delta P divided by Q, where R stands for resistance, delta P is the pressure gradient, and Q is the flow. Resistance R to laminar flow of an incompressible fluid having viscosity eta through a horizontal tube of uniform radius R and length L is given by the Poiseuille's law for resistance. R equals 8 eta L divided by pi times R to the power of 4. These equations can be rearranged such that Q equals delta P divided by R, or delta P equals Q times R. Effect of radius on resistance. Doubling the radius of a tube decreases resistance by a factor of 16. Viscosity describes the frictional forces which act between the layers of the fluid as it flows down a tube. Fluids resist flow because of the phenomenon of viscosity. Units are Pascal seconds. Turbulent flow. Turbulent flow describes the situation when any fluid, gas or liquid, flows unpredictably with multiple eddy currents and is not parallel to the sides of the tube through which it is flowing. Orderly arrangement of the molecules is lost and the fluid swirls and eddies, and this increases resistance to flow. The flow of particles is not parallel to the sides of the tube. The leading edge of a column of a turbulent fluid appears flat. Maximum flow velocity in the tube center is lower due to turbulence. Increased mixing due to turbulent flows results in stronger transfer of momentum between the fluid particles, and this increases the flow velocity of the fluid in the area close to the wall of the tube. As flow is unpredictable, no single equation defines the rate of turbulent flow. Examples of causes of turbulent flow includes the tube is unevenly shaped, fluid flows through an orifice, fluid flows around sharp edges, or occurring from laminar flow when flow velocity is high, exceeding the critical velocity. Turbulent flow is proportional to the square root of the pressure gradient. Unlike laminar flow, which is proportional to the pressure gradient, turbulent flow is also proportional to radius to the power of 2, 1 divided by length, and 1 divided by density of the fluid. Reynolds number is a number calculated to identify whether fluid flow is likely to be laminar or turbulent. It is the ratio of inertial to viscous forces, and the formula is Reynolds number equals rho v d divided by eta, where rho is the density of fluid, v is the velocity of fluid, d is the diameter of the tube, and eta is the viscosity of the fluid. When Reynolds number is less than 2000, flow is likely to be laminar and viscous forces predominate. When Reynolds number is more than 2000, flow is likely to be turbulent. When Reynolds number is 2000, flow becomes liable to become turbulent. The transition of laminar to turbulent flow can occur at angles or constrictions of the tube due to increased local velocity, and this increases resistance. The cutoff point of Reynolds number 2000 to delineate laminar from turbulent flow has been obtained empirically from in vitro experiments. When Reynolds number is 2000 to 4000, both laminar and turbulent flow are anticipated. When Reynolds number exceeds 4000, flow is likely to be completely turbulent and inertial forces dominate. Reynolds number is dimensionless. It has no units, as the units of all the variables in the equation cancel out each other. Critical flow is the point above which turbulent flow commences and occurs above Reynolds number 2000. Critical velocity is the velocity above which laminar flow in a tube becomes turbulent and occurs above Reynolds number 2000. Critical velocity is proportional to the viscosity of fluid divided by density of fluid times radius of the tube. Main points to remember: viscosity is the important property for laminar flow, density is the important property for turbulent flow, and Reynolds number of 2000 delineates laminar from turbulent flow. Next, we will be moving on to practical applications of fluid dynamics, laminar and turbulent flow. As a recap, flow equals delta P, which is the pressure gradient, divided by R, resistance. This can be rearranged as R equals delta P divided by Q, or delta P equals Q times R. The Hagen-Poiseuille equation for laminar flow is flow equals delta P times pi times R to the power of 4 divided by 8 eta L, and Reynolds number is rho Vd divided by eta. Resuscitation with IV fluids. Strategies to increase flow rate during IV fluid resuscitation. Increase the pressure drop along the tube, such as by using pressure bag, or increase the height of the IV fluid bag relative to the IV cannula. The flow of fluid via an intravenous infusion will double if the driving pressure is doubled. Increase the radius of the tube. The flow rate can increase by up to 16 times if the internal diameter of the cannula is doubled. In practice, the increase in flow may not be quite as impressive and is influenced by many other factors. Nonetheless, the use of one or multiple short and wide bore cannulae to achieve rapid restoration of circulating volume via IV fluid resuscitation is highly recommended. These values vary according to manufacturer. For a 14 gauge short IV cannula, the color is orange or brown, diameter is 2 mm, length 45 mm, flow rate 250 mL per minute. For a 16 gauge short IV cannula, the color is grey, diameter is 1.7 mm, length 42 mm, flow rate is 170 mL per minute. For an 18 gauge, the color is green, diameter 1.2 mm, length 40 mm, flow rate is 90 mL per minute. For a 20 gauge, color is pink, diameter is 1 mm, length 32 mm, flow rate is 55 mL per minute. For a 22 gauge, color is blue, diameter is 0.28 mm, length is 25 mm, flow rate is 25 mL per minute. For a 24 gauge, the color is yellow, diameter is 0.07 mm, length 19 mm, and the flow rate is 24 mL per minute. These flow rates from IV cannulae are measured by having distilled water flowing through a 110 cm tubing with an internal diameter of 4 mm at a temperature of 22 degrees Celsius and under a pressure of 10 kPa. Avoid long narrow diameter infusion tubings and use short wide diameter tubings to increase the flow rate. Decrease the viscosity of the fluid to increase flow rate. For example, for packed red blood cells, decrease viscosity by warming the packed cells or dilute it with normal saline. Crystalloids flow faster than colloids or packed cells due to its reduced viscosity. Another method is to reduce the length of the tube to increase flow rate. The flow of fluid will double if the length of the cannula is halved. Fluid resuscitation through long central venous catheters are ineffective as increased length of the cannula increases resistance and this reduces flow rate. Avoid unnecessary three-way stopcocks and extension tubings. Next, we move on to gas flow. Gas flow is a mixture of laminar and turbulent flow and behaves approximately according to the previously mentioned principles. Airway resistance. Normal airway resistance in healthy adults is between 0.5 and 2.5 cm H2O per liter per second. Airway resistance may increase if there is a reduced patency or diameter of the airways or increased length of the airway and ventilator circuit. Resistance to flow is 8 eta L divided by pi radius to the power of 4. When there is a reduction in the radius of the tube, there is increased velocity, increased turbulence, and increased resistance. A given number of fluid particles have to move faster through a narrow section of the tube in order to keep the total flow the same, thus there is an increase in velocity. Since Reynolds number is rho Vd divided by eta, when there is an increase in velocity, there is an increase in turbulence, and turbulent flow is proportional to the square root of delta P, which is the pressure gradient, and when delta P increases, resistance increases, as resistance equals pressure gradient divided by flow. Obstruction of airflow may be caused by changes in the airway, changes in the wall of the airway, or changes outside the airway. Examples of causes of changes inside the airway includes retained secretions such as in COPD, pneumonia, asthma and bronchiectasis, blood clots, vomitus, foreign body, tumor, water condensation in the ventilator circuit, obstruction of the artificial airway or breathing circuit, and congenital anomalies. Examples of changes in the wall of the airway that can obstruct airflow includes edema, for example due to direct trauma in blunt trauma, burns or smoke inhalation, infection such as croup, epiglottitis and bronchiolitis, and angioedema. Inadequate muscle tone can cause airway obstruction such as in OSA, reduced consciousness such as in head injury, sedatives and raised ICP, neuromuscular disorders such as myasthenia gravis, and neurocognitive disorders such as after a stroke or Parkinson's disease. Bronchospasm, tumor, and excessive granulation tissue or fibrosis such as in tracheal stenosis, supraglottic stenosis, and subglottic stenosis can obstruct the airway. Examples of changes outside the airway that can obstruct airflow includes hematoma, abscess, retrosternal goiter, tumor, etc. In the pediatric population, there are several factors that predisposes them to airway obstruction compared to adults. They have a large and round occiput, unlike the flatter adult skull. The occiput flexes the head forward in the supine position, and this can obstruct the airway. They have narrow nostrils, and the newborn is an obligate nose breather. Nasal obstruction, for example by choanal atresia of the newborn, can cause airway obstruction. Infants have loose teeth that may be aspirated during airway management, and this can obstruct the airway. Infants have a large tongue relative to the mouth, and the tongue easily obstructs the larynx in reduced consciousness. Adenoids or tonsils may fill the pharynx, and this can cause obstructive apnea and increases the difficulty of manual ventilation. The larynx of the infant is higher in the neck. For infant is C2, C3 level, and adults C4, C5 level. The tongue or soft tissue easily obstructs the larynx when it is higher. There is a higher incidence of laryngospasm in children compared to adults. The cricoid ring is narrower than the glottic opening, and this creates a funnel-shaped larynx that places children at risk for airway obstruction from subglottic edema, such as in croup or trauma. The laryngeal and tracheal diameter is very narrow. A small decrease in caliber of the airways due to inflammation or edema may critically impair the capacity of the exhausted baby to maintain effective ventilation due to increased airway obstruction, resistance to airflow, and work of breathing. Infants have soft and easily compressible laryngeal and tracheal cartilage. Excessive flexion or extension of the head or external laryngeal pressure can cause airway obstruction. They have a short neck, and this makes it difficult to identify laryngeal landmarks for emergency surgical airway. They have a short trachea, and head position changes may lead to accidental extubation or endobronchial intubation. In intubated patients, the major contributor to increased airway resistance is the internal diameter of the endotracheal tube. Airway resistance varies directly with the length and inversely with the diameter of the airway. During intubation, the largest appropriate sized endotracheal tube must be used to reduce airway resistance contributed by the endotracheal tube. This is especially important in patients who are spontaneously ventilating, as they use their own respiratory effort to overcome the tube's resistance. The pressure gradient, which represents work of breathing, equals flow times resistance. When there is an increase in resistance, there is an increase in pressure gradient required to maintain a constant airflow. The endotracheal tube may be shortened to reduce airway resistance, for the ease of airway management, and to reduce mechanical dead space. Once the endotracheal tube is in place, its patency must be maintained as secretions or blood inside the ET tube increases airway resistance. A tracheostomy tube has a shorter length compared to a standard ETT, and this reduces airflow resistance, work of breathing, and improves respiratory mechanics and facilitates weaning from a mechanical ventilator. The ventilator circuit may also contribute to increased airway resistance. Reduce the angles and constrictions in breathing systems to reduce turbulent flow and reduce resistance. Remove secretions in the circuit to reduce airway resistance. Take note of malfunctioning valves or switches which can increase airway resistance. The heat and moisture exchanger normally produces airway resistance of 0.1 to 2 cmH2O. However, airway resistance may increase if there is obstruction of the HME, for example, by mucus or blood, or because the expansion of the saturated heat exchanging material. HME should be changed every day or when there is excessive secretions. Vaporizers. Vaporizers with low airway resistance, such as the Oxford Miniature Vaporizer, can be placed inside the circuit, such as in the portable tri-service apparatus for emergency use in the field. The patient can draw air through the OMV during spontaneous or controlled ventilation. However, some vaporizers, such as the Plenum Vaporizer, Measured Flow Vaporizer, and Aladdin Cassette Vaporizer, have high resistance to airflow, and these have to be placed outside the breathing circuit to avoid increased work of breathing. When there is increased airway resistance, this may lead to increased work of breathing and potential for respiratory failure. Pressure gradient equals flow times resistance. Pressure gradient also equals flow times 8 eta L divided by pi radius to the power of 4. The pressure gradient reflects the work of breathing imposed on the patient. Driving pressure, delta P, to maintain the same airflow Q must be increased by a factor of 16-fold when the radius R of the airway is reduced by only half of its original size. Increased airway resistance results in increased driving pressure and increased work of breathing. Relief of airflow obstruction is an effective way to reduce the work of breathing. Reduction of turbulent flow results in reduced airway resistance and reduced work of breathing. Laminar flow is more efficient than turbulent flow and so requires less expenditure of energy and therefore less power. If the driving pressure is held constant, increased airway resistance produces reduced airflow, reduced minute ventilation, and hypoventilation. If the increased airway resistance is sustained over a long time, fatigue of the respiratory muscles may occur, and this may produce ventilatory failure, which is the failure of the respiratory system to remove CO2 from the body, resulting in high PaCO2, and oxygenation failure, which refers to the failure of the heart and lungs to provide adequate oxygen for metabolic needs. If ventilatory or oxygenation failure occurs, the patient may require mechanical ventilation. A mechanical ventilator is a machine or a device that can fully or partially substitute for the ventilatory work accomplished by the patient's muscles. Referring to the equation of motion for the respiratory system, muscle pressure plus ventilator pressure equals lung volume divided by compliance plus resistance times flow. If there is increased resistance, there is a need to increase pressure. If the patient's own muscles cannot produce that pressure, they may need assistance from a ventilator. Airflow resistance of a patient ventilator system may be monitored using a pressure volume PV loop display. Increased bowing of the PV loop suggests an overall increase in airflow resistance. Increased airflow resistance may be caused by increased inspiratory flow or increased expiratory flow resistance. When there is increased inspiratory flow, there is bowing of the inspiratory limb from A1 to A2. If there is increased expiratory flow resistance, there is bowing of the expiratory limb from B1 to B2. Partial upper airway obstruction. As gases flow through the constriction, there is increased flow velocity and increased likelihood of turbulent flow. Turbulent flow is chaotic and less organized than laminar flow. It is less efficient at delivering gas to the alveoli. Manipulation of the variables to reduce the Reynolds number increases the likelihood of laminar flow occurring, and this increases gas delivery to the alveoli capillary interface. Reynolds number equals density of fluid times velocity of fluid times diameter of the tube divided by viscosity of the fluid. Heliox is 79% helium plus 21% oxygen. It is 70% less dense than air. It improves airflow by up to 1.73 times when used for airway obstruction. However, this does not necessarily improve oxygenation, as FiO2 is still 21%. Nitrous oxide has a higher density than oxygen and should be used with caution in airway obstruction, as it could increase air turbulence. Increasing the diameter of the constriction, for example with surgical or medical interventions, reduces flow velocity and reduces turbulent flow. Reducing flow velocity could reduce Reynolds number, but this reduces overall flow and it would be counterproductive. Cricothyroidotomy. This is an emergency surgical airway used in cannot intubate, cannot ventilate situations. It could be needle cricothyroidotomy or surgical cricothyroidotomy. A narrow bore or wide bore cannula can be used during needle cricothyroidotomy. Narrow bore cannulae, most are about 2 mm internal diameter, is usually inserted as a cannula over needle technique through the cricothyroid membrane. Ventilation is based on two important principles. A high driving pressure is required to inflate the lungs due to increased resistance to flow through the cannula, and expiration must take place through the patient's upper airway. The driving pressure equals flow times resistance. When there is increased resistance, for example due to the narrow bore of the cannula, the driving pressure must increase to maintain adequate airflow. A specifically designed ventilating device such as the ManuJet injector is strongly recommended. A driving pressure of 1 bar using a ManuJet may be adequate to ventilate most slim patients, and this reduces the risk of barotrauma. Neuromuscular blockade and inserting a supraglottic airway device to maximize the expiratory route increases the success of the technique. Ensure that the chest falls completely before the next inspiration to avoid volutrauma. Wide bore cannulae can be used in needle cricothyroidotomy. These are usually more than 4 mm in diameter. 4 mm internal diameter endotracheal tube is the minimum caliber through which an adult can exhale with adequate speed to maintain a normal minute volume. Insertion of wide bore cannulae may be via cannula over needle technique, such as the quick track device, or by using those requiring Seldinger insertion technique, such as the Melker cricothyroidotomy device. Ventilation can be achieved with a low pressure gas source, such as a standard anesthetic machine, due to reduced airway resistance compared to the narrow bore cannula. Large bore cannula require that the upper airway is obstructed during inspiration to avoid the ventilating gas being vented out via the upper airway, and this can be achieved using a cuffed cannula or using a supraglottic airway device with the proximal end obstructed. Surgical cricothyroidotomy uses a 6 mm internal diameter tracheal tube or tracheostomy tube via the cricothyroidotomy incision. Ventilation can be achieved with a low pressure gas source, such as a standard anesthetic machine, due to reduced airway resistance compared to the narrow bore cannula. Measuring gas flow or gas volumes. Gas volume can be measured directly or indirectly. Direct methods include the usage of gas meter, vitellograph, water displacement spirometer, etc. Indirect measurement methods include the use of Flowmeter, peak Flowmeter, Pneumotachograph, Wright respirometer, thermal flow sensor, etc. Flowmeters. Flowmeters are constant pressure variable orifice devices. Rotameter is a trade name, which are calibrated for a specific gas, which gives a continuous indication of the rate of gas flow. Opening the needle valve causes gas to enter the tapered tube. The needle valve controls the gas flow through flowmeters via manual adjustments. To increase the flow of gas, the valve is turned in an anti-clockwise direction. The space between the needle valve and the orifice which gas enters increases, and this allows more gas flow into the tapered, transparent plastic or glass tube. The bobbin is held floating within the tapered tube by the gas flow passing around it. Effect of gravity on the bobbin is countered by the gas flow pushing the bobbin upwards. As the bobbin floats, a constant pressure difference across the bobbin exists. The higher the gas flow, the higher the force pushing the bobbin upwards against gravity, the higher the bobbin rises. The orifice through which gas flows enlarges with increasing flow rate, while the pressure drop across the orifice remains constant. The bobbin rotates as gas flows past it. Slits or flutes cut into its side at the top of the bobbin enables rotation within the center of the gas stream without having the bobbin touching the tube wall. This prevents the bobbin from sticking to the tube wall due to dirt or static electricity. The dot on the bobbin allows better visualization of bobbin rotation. Reading the flow meter depends on the type of bobbin. For example, for ball type bobbin, read the center of the bobbin, and for non-rotating H float, skirted or non-skirted, read the top of the bobbin. The clearance between the bobbin and the tube wall widens as the bobbin rises with increasing gas flow. As the bobbin rises from point A to point B, the clearance increases from X to Y. At low flow rates, clearance is longer and narrower, as if gas flowing through a tube. At the bottom of the flow meter, flow is laminar, and flow is a function of gas viscosity following the Hagen-Poiseuille equation. At high flow rates, clearance is shorter and wider, as if gas flowing through an orifice. At the top of the flow meter, flow is turbulent, and flow is a function of gas density. Reynolds number exceeds 2000. Kindly refer to the video discussing flow meters for further details. Wright respirometer. This device measures tidal volume and minute volume. Components. It consists of an inlet and outlet, a rotating vane surrounded by slits. The vane is attached to a pointer. On the outer surface of the case, it has an on-off button and reset button. It has two display dials. The outer display is calibrated at 100 mils per division. The smaller inner display is calibrated at 1 liter per division. Mechanism of action. It is a one-way system. It allows the measurement of gas volume if the flow of the gases is in one direction only. The correct direction for gas flow is indicated by an arrow. It works by directing the breathing gases through oblique slots in a small cylinder enclosing a small vein which is made to rotate. Slits surrounding the vein create a circular flow in order to rotate the vein. The vein does 150 revolutions per liter of gas passing through. The spindle on which the vein is mounted is connected to a pointer which moves over a dial that indicates the volume of gas passed. It is usually positioned on the expiratory side of the breathing system to minimize the loss of gas volume due to leaks and expansion of the tubing, as the expiratory side has a lower pressure than the inspiratory side. Advantages: it is small and portable and weighs less than 150 grams. It is able to measure tidal volume without requiring an electrical supply. It has low resistance of 2 cmH2O at 100 liters per minute. Disadvantages: its accuracy is affected by many factors. For clinical use, the respirometer reads accurately the tidal volume and minute volume within ±5 to 10% within the range of 4 to 24 liters per minute gas flow. The respirometer should be positioned as close to the patient's trachea as possible to improve accuracy. A pediatric version exists with a capability of accurate tidal volume measurements between 15 and 200 mL. A minimum flow of 2 liters per minute is required for the respirometer to function accurately. It underreads at low flow due to friction and inertia, and overreads at high flow due to momentum. Water condensation, for example due to expired moisture, can prevent the veins from rotating freely, and this causes the pointer to stick. It is unable to measure bidirectional flow. Gases that flow back through the device do not register, since the flow in the reverse direction impinges on the bottom edge of the vein without producing any rotational movement. It does not have any alarms, and there are no display for measured volume as there is no electrical output. Alternative versions of the Wright respirometer exist, such as that using light reflection to measure the tidal volume, or other designs that use semiconductive devices, which is sensitive to changes in the magnetic field. Tidal volume and minute volume is measured by converting these changes electronically, and an alarm system can be added. Pneumotachograph. This is a constant orifice variable pressure flow meter. It measures gas flow. From this, gas volume can be calculated. Flow rate equals volume divided by elapsed time, and volume equals flow rate times elapsed time. Components include a tube with a fixed resistance, such as a bundle of parallel tubes, known as the Laminar resistor, and two sensitive pressure transducers on either side of the resistance. Mechanism of action. As gas flows through a fixed resistance, there will be a drop in pressure. A differential pressure transducer senses the pressure gradient across the resistance. The change in pressure is proportional to the flow. The pressure change is only a few mm of water and is linearly proportional over a certain range to the flow rate of the gas passing through the resistance. Tidal volumes can be summated over a period of a minute to give the minute volume. Advantages. It can measure bidirectional flow, both in inspiration and expiration. It is highly accurate and is able to display the readings electronically. Factors affecting the readings in a pneumotachograph. Location. The pneumotachograph should be placed between the breathing system Y-piece and the tracheal tube. Gas composition. Nominal values of gas composition need to be known with sensors calibrated accordingly. Gas viscosity affects values. Temperature. Usually the sensor's software provides default values for a typical patient. Humidity. Water vapor condensation at the resistance encourages the formation of turbulent flow, and this affects the accuracy of the measurement as it is designed to measure laminar flow. This can be avoided by heating the parallel tubes. Moisture can also affect measurement and generation of pressure drop. Pressure pots should be directed upwards to prevent fluid from draining into them. Apparatus dead space. Sensors need to have a minimum dead space of less than 10 mL for adult flow sensors and less than 1 mL for neonatal sensors. Operating range of the flow sensor. Sensors are designed to function accurately with a very wide range of tidal volumes, i.e. ratios, frequencies and flow ranges. Intersensor variability. Individual sensors can have different performances, however there should be no need for individual device calibration of flow or pressure characteristics. Combine Pneumotachograph and Pitot tube. The Pitot tube Flowmeter consists of two pressure pots. One faces the direction of gas flow and the other is perpendicular to the direction of gas flow. To measure bidirectional flows, inspiration and expiration, the two pressure pots face in opposite directions within the gas flow. These pressure pots are connected to pressure transducers. Mechanism of action. The pressure difference between the pots is proportional to the square of the flow rate. Flow rate is measured and tidal volumes can be calculated. Density and viscosity of the gases can alter the accuracy, which can be compensated for by continuous gas composition analysis via a sampling tube. By combining a pneumotachograph with a Pitot tube, this increases accuracy of gas flow measurements. It can calculate and measure compliance, airway pressures, gas flow, and can produce volume pressure or flow volume loops. This combination device can be used accurately even in neonates and infants. Laminar flow operating theatres. In this system, this describes a body of air within the demarcated area which moves with uniform velocity along parallel flow lines and in a single direction. This system is costly. Laminar flow systems can generate 300 air exchanges per hour, compared with up to 25 an hour in a conventionally ventilated turbulent air theatre. Laminar airflow systems do not reduce surgical site infection rates. Some small single-center studies demonstrate reduced infection rates, but some very large surveys involving 80 to 100,000 patients demonstrated increased surgical site infection rates. Data from the National Joint Registry and Hospital Infection Surveillance Systems have revealed statistically significant greater deep infection rates in laminar flow theatres, but the exact reason for this is unclear. It is speculated that one factor is the greater use of forced air warming blankets, as laminar airflow systems increases heat loss from the patient's body by increasing convection losses. Convection is proportional to the square root of airspeed. Strategies of proven benefit to reduce surgical site infection includes administration of appropriate antibiotic prophylaxis and maintaining patient normothermia. Combined spinal and epidural sets. A combined spinal epidural technique can be done using a 26-gauge spinal needle of about 12 cm in length with a standard 16-gauge Tohi needle. The Tohi needle is first positioned in the epidural space, and then the spinal needle is introduced through it to reach the subarachnoid space. High pressure is required to inject through the spinal needle because of its small bore. This might lead to accidental displacement of the tip of the needle from the subarachnoid space, resulting in failed or partial subarachnoid block. To prevent this, the spinal needle is anchored to the epidural needle to prevent displacement in some designs. Dynamics of blood circulation. This will be discussed in a future video. These are my references. Thank you.